Thank you, Dr. Sandeep Mandal, taking us to the CKM's axis. And next we have Dr. Tamonash Bhattacharya, who is going to speak on from prescriber to protector. So let's see what he wants to say as far as the mindset shift. Come here, please. Let's see here. Anyway, Dr. Tamonash Bhattacharya is a known face, basically. And he is again a senior physician in city of Calcutta, and he is attached to the Municipal Corporation of Kolkata and does a brilliant job in tuberculosis management. And he actually sees all the referrals from the various hospitals as far as tuberculosis is concerned. And so over to you, Dr. Tamonash.
So basically we are sharing some of our slides, PPTs are common to all. However, this is it's not yes. From Kashi to Kolkata, or rather from Kolkata to Kashi, there is a bridging line, that is the river Ganges. Similarly, in the context of the CKM, the bridging line is metabolic disorders. There is a flow of metabolic disorders which can affect from different structures within our body, and of course, the major burn which is really affecting the social as economical burden of the country, that is the renal and cardiological burden problems. I will skip so many slides, of course, due to paucity of times. We all know the definitions. We know even the concept of CKM syndrome. This is a metabolic syndrome, and there is shared mechanisms: inflammation, insulin resistance, and of course endothelial dysfunctions. So early identification may prevent the downstream CV events. And of course, what the onset of the discussion, which we talked, that multidisciplinary approach, that is the ideal situation. This is the scientific statement. Is it a syndrome? We all know about the slides. There is a multiple comorbid, there are multiple pathophysiologies, multifactorial disorders, landing up to so many health disorders, mostly affecting the metabolic features within the body. These are pathophysiological interactions among metabolic risk factors, CKD, and cardiovascular system, leading to multi-organ dysfunction and high rate of adverse CV outcomes. Not only the mortality of the patients, it also affects the morbidity of the patients. So CKM syndrome is a health disorder due to connection among heart, kidney, diabetes, obesity, leading to poor health outcomes. So CKM is a continuous process, risk factors, metabolic disease. So there is a therapeutic shift, particularly after the advent of newer armamentarium, so in our diabetic as well as hypertensive baskets. We are having SGLT2 inhibitors and GLP-1 receptor agonists, providing organ protection, which is mostly important. In our undergraduate days, we used to taught that, okay, if a patient coming with a borderline dysglycemia, borderline hypertension, you can wait. But now, the paradigm has been shifted, and we are addressing that if the patient is picked up early, and if we can aggressively manage the patient at the earlier stage, we can prevent the target organ damage. There is a shift in and we have armamentariums, which actually, if you consider the newer armamentariums, doesn't fall glycemic load that much, doesn't cause hypoglycemia per se, but giving you the additional benefits, metabolic benefits. So, this is the dual weight renal axis concept, and in the perspective of our DRWA, I just change a little bit. This is a diabetic renal weight axis. This is addressing, this is the challenge and goal of the DRWA roadmap. These slides already shared by my previous speakers. So mechanism of cardiorenal protection is important, reduction in glomerular hyperfiltration, improved metabolic profile and weight reduction, reduced inflammation, oxidative stress, improved vascular endothelial function. So these are the trials which definitely showed risk reductions, which is being transcribed in our day-to-day clinical practice as well. So integrating evidence into practice, SGLT2 inhibitors recommended for CKD and heart failure, GLP-1 receptor agonists beneficial for obesity and CV risk, combination therapy provide additional benefit, and guidelines adoption increases globally. So recognize the CKM syndromes early, collaborate with nephrology and endo, prioritize therapies with proven outcome benefits, and focus on prevention of CV and renal events. These slides already being shared. So staging is also shared. So I don't repeat those slides. Now regarding the management of staging, I just want to just touch on one point. That is some aspects which were not previously addressed. We didn't ask the patient for snoring in our previous days. We didn't ask the patient for gut habits. So gut dysbiosis is equally important. We are now considering MSLD as our key components. So addressing the liver fat load is equally important for early initiation of management. As well, we have to think of the patient's sleep habit, not only the sleep duration of the sleep, pattern of sleep. How the patient is having his adequate sleep, snoring, OSA, which should be addressed. And these things are incorporated in the present management basket. So risk enhancing factors, some are modifiable. Definitely social determinants of health are not modifiable by as individual physician or even the healthcare professionals. This is a social aspect, this is a policy aspect, this is a different issue. But chronic inflammatory conditions, high risk demographic groups, higher burden of adverse SDOH, this war situation, COVID situations, all these are affecting adversely the SDOH, mental health disorders, sleep disorders, sex-specific breast cancer, and particularly endocrine disruptors. Usage of this kind of starting from commercial colors, so many carcinogens, so many agents, chemicals in our day-to-day lifestyle. These are all very much important. We hardly ask the patient for the patient goes to the gynecologist for the menstrual disorders, but we never consider if the holistic approach is there, the patient should be picked up for his metabolic outcome. The patient is going to the dermatologist, but we never think whether the patient is having acanthosis, whether this is a marker of IR. So these are total approach should be more comprehensive as well as more conducive. Screening, already told, screening for biological factors, screening for SDOH, both are important. So as early as we can pick up the thing, we can address the situation, we can prevent the adverse outcome. That is our motto. So for the perspective of a prescriber, it's a role, the role has been shifted as a protector. We can counsel the patient as well as the patient party. In my introduction that Dr. Patni was saying that I am involved in the TB management. Yes, we actually, when we identify a TB case as a communicable disease, we try to find out its immediate contacts. Similarly, when the patient is coming along with his patient, his or her party, we never hardly ask whether the similar situation, similar clinical symptoms, manifestations is being having by the patient party as well. And we never ask the CKD patient that you should teach your downstream line, your family member, your son, your nephew, your daughter, that how to, that this is a first degree relative of a CKD patient is a highest risk probable. So we never teach in that way. So it's a role of a physician is also not only a protector, a savior in that sense. So risk prediction and prevent equations, AHA predicting risk of a CVA. So there risk calculators are there, the incompleteness is there. There are so many, BMI is not often overestimated. NT-proBNP has got its own limitation. High sensitive troponin T or troponin I as well. These all are markers, but markers have their limitations if we don't counsel adequately. So risk prediction, building a risk calculator, and ultimately to minimize the risk. So potential to guide therapeutic choice and at-risk population, we have to identify the higher risk group, that family members, the demographic profile. So these things we have to take in account. So approach already dealt. So future directions. This is earlier intervention in metabolic disease, precision medicine approaches, emerging cardiometabolic therapies, and improved population screening. Screening is very important. So key takeaways should be CKM continuum links obesity, metabolic disease, CKD and CVD. Modern therapies provide organ protections. Major trials support the integrated management, and multidisciplinary care is essential. So this is our message, and thank you for your patient hearing.
Thank you, Dr. Tamonash. Excellent presentation, I would say. We are moving away from prescriber to protector, and you have to risk stratify the patient, individual as well as in the community.